So during our lunch break here, we have another presentation. Dr. Ashraf Hanna is the leading doctor at the CRPS, RSD, fibromyalgia, Lyme disease, PTSD, and depression with the breakthrough IV ketamine infusion therapy. He completed a pain management fellowship at the prestigious Cleveland Clinic in Ohio. Sorry, give me a minute to go through my notes here. Dr. Hanna is the director of pain medicine at the Florida Spine Institute in Clearwater, Florida. He's the clinical assistant professor of Nova and LeCom University and the past president of Florida Academy of Pain Medicine. Dr. Hanna has a brief presentation for you, and then we are going to do a drawing. We will draw one winner and then two alternates. He is pleased to offer 10-day ketamine infusion for people that qualify under the Medicaid guidelines for hardship. It's a 10-day ketamine infusion. It's a service that he is providing, but there are qualifications. So in the event that the first winner does not qualify, we have a first alternate and a second alternate. So we'll be drawing 3 tickets. Have your tickets ready after his presentation, and you will need to provide all of your contact information to Dr. Hanna and to Mike, his partner. Please welcome Dr. Hanna. Thank you. This is the pointer. That's
Oh, I think I don't have. I will talk to him. I think, yeah, it's okay. Hi, everybody. I would like to thank Gracie for giving me the honor to be here. And I hope I can help you understand a little bit about CRPS and maybe other disease process. I apologize, I don't have PowerPoints, especially you guys are eating, so just gonna make it a nice conversation and rely more on questions from your side. And that's my mistake, because I thought I was just gonna be at the exhibitor hall, but she was generous enough to give me some time here. So I'm an anesthesiology background and pain management specialist. So I do all kinds of pain management procedures, radiofrequency, injections, spinal cord stimulators. But really, lately in the past several years, my main hobby was treating CRPS and using IV ketamine. So just who has CRPS from the audience here? Okay, so we have quite few who have CRPS, and we have quite few who have probably other disease process. So we'll try to maybe give the presentation to both conditions. I would like to give a brief presentation about CRPS, which I personally believe it should be called CCPS. CRPS stands for Complex Regional Pain Syndrome, but we believe it's more of a complex central pain syndrome, since really it affects the whole body, as any one of CRPS patients now experience. Basically, for those of you who don't have it, and I don't wish for anyone to have it, it's persistence of severe pain for quite some time after the resolution of the injury. Pain is quite intense. It's very severe burning pain, associated with sensitivity, hypersensitivity, hyperpathia, which is persistence of pain with light touch after we stop the touch, allodynia, which is severe pain to light touch, presence of swelling, color change, temperature changes, presence of edema, presence of weakness, nail growth changes, hair growth changes, and a lot of dystonia and dystrophic changes. So the problem with the CRPS treatment, that it has to be multidisciplinary treatment protocol with medication management, physical therapy, initially injection procedures. We do lots of sympathetic blocks, initially, and then the IV ketamine therapy. What I would like to emphasize is, in the past, we used to reserve the ketamine as a last resort. Now, because we understand that CRPS is more of a central sensitization syndrome, that we should start the ketamine as soon as we can. Now, what's the pathology of CRPS? Why does it develop? And a lot of patients have a lot of confusion about why it happens. And a lot of them don't understand, why am I having all those symptoms from just a little trauma? And I'll try to minimize it in a very simple terms in a couple of minutes here. So if you can just listen carefully. An average patient will just get a trauma, get injury, the pain will go away within a few weeks and everything is fine. For some unknown reason, maybe like what Dr. Young was talking about, genetic implications, some patients, that pain does not go away. For some patients, those pain impulses keeps bombarding the brain. The brain gets stimulated, the brain gets inflamed. We have certain receptors in the brain, NMDA receptors, get irritated, produce chemicals called glutamate. A lot of glutamate causes what we call glutamate excitotoxicity. Glutamate excitotoxicity can irritate the brain. There are certain cells in the brain called glial cells. We used to think glial cells don't do anything. Now glial cells are severely incriminated in a lot of pathology of the CRPS and a lot of the central sensitization syndrome. When glial cells get irritated or inflamed by this massive bombardment of glutamate in the brain, they release what we call cytokines. Cytokines are cytotoxins, neurotoxins. They go all over the body and damage the nerves. And this is where we see the systemic manifestations of CRPS. So they go to the sensory nerves and they cause the pain, damage the sensory nerves. It primarily affects the small fibers. That's why you may hear from many doctors, CRPS is a small fiber neuropathy, and it is. Now, the autonomic fibers in the body are made of small fibers. So those small fibers get affected. At the autonomic side of the body, you get the blood vessels. That's why you get blood vessels fails to contract, to dilate, they go crazy. So that's why you get the color changes, the temperature changes. It goes into the gut, intestine, stomach. That's why a lot of CRPS patients may develop what we call gastroparesis. So this is why when I first started to talk, I said it's a complex central pain syndrome because it's a diffuse small fiber neuropathy. So this is how you develop the pain. This is how you develop all the sensitivity. You develop the color change, the temperature changes, the autonomic dysfunction, the gastroparesis. Also, you develop the POTS syndrome, postural orthostatic tachycardia syndrome, which when you try to stand up, you get dizzy and you fall because of rapid tachycardia. All of these are simply a result of the small fiber neuropathy that is a result of the cytokine release. So to make it simple again, injuries irritate the brain, glutamate, NMDA receptors, glutamate, throw it to the glial cells, release cytokines. Cytokines go all over the body, because small fiber neuropathy, you get all the systemic manifestations of the CRPS. That is why it is a systemic illness. There is also implication of the autoimmune system, in that as well. So let's talk about treatment for CRPS. And to make it quick, of course, as I said, medication management, anti-inflammatory, muscle relaxants, anti-seizure medications, antidepressants, sympathetic blocks, stellate ganglion blocks, spinal cord stimulators, and then the IV ketamine. And as I said, the IV ketamine, I believe, should be as early as possible to block that whole cascade that I just talked to you about. So as soon as you know you developed CRPS, ask your doctors for ketamine. He can do all the other blocks until you get to do the ketamine, but that should be a priority. And I'll show you later on a video of a few patients, and I'll discuss that with you, why this is important. Now, for other patients who don't have CRPS, I'll tell you a very brief story how my clinic turned out from just IV ketamine for CRPS to IV ketamine for a lot of other illnesses. I had a patient who was referred to me for pain management. She simply had, from a local primary doctor, she had simply something called lichen sclerosis. Most of you probably don't know it. It's a simply autoimmune condition of the skin where there is big lesions and severe pain. When I examined her, I noticed that the area with the lichen sclerosis were very sensitive. It had a picture very similar to the CRPS pain. So it's basically a type of a central sensitization pain as well. I told her, instead of giving you all those Percocet that you have been taking and Oxy, why don't we try on ketamine? She said, I've been 20 years like this in severe pain, do whatever you want to do to me. I said, fine, let's try it. We tried it. Her pain went from 10 to 0 or 1 from the ketamine. That was a major breakthrough. I got a call a few weeks later from USF, University of Florida, University of South Florida, because her treating doctor was the head of the dermatology department, since this is a rare disease. And he asked, I'm not sure what you did to her, but I've been with her for 15 years and now she's pain-free. And if you are willing to come, help with the presentation in our gradual grand rounds. So I went to the grand rounds, and while they're presenting the case, and again, I'm just a pain management physician, so they're presenting the case, their chief resident presenting it, and he mentioned that her pain went great, it improved from 10 to 0 or 1, and her lesions became smaller. So this was a very interesting point, that her lesions became smaller. Ketamine actually treated her autoimmune illness and reduced the size of the lesions of the lichen sclerosis. That was really like what prompted, a lot of thinking in my head. And I said, well, we know from CRPS that one of the mechanisms of CRPS and IV ketamine is autoimmune as well. So ketamine probably has a very strong role in the autoimmune diseases. So I said, let's try and play with autoimmune diseases. So I started treating quite a few autoimmune diseases. I had patients with multiple sclerosis, with dropped foot, who regained full strength back. I had patients with rheumatoid arthritis. I had patients with psoriatic arthritis, with lupus. I had a patient with lupus that I just saw, a few days ago, that she just stumbled, on me by luck on the online when she was trying to Google, how to commit suicide with no pain. And then she stumbled on No Pain Hannah by luck. So she came in and I just saw her. It was 2 months after her treatments and she was pain-free. So this is really a significant news for patients with autoimmune disease. I've tried it with patients with neuroleptic malignant syndrome. Somebody was talking about malignant hyperthermia, neuroleptic malignant syndromes. It's a disease with massive rhabdomyolysis. Oh, okay. Okay. And anyway, so we treated a lot of patients, Lyme disease, depression, and all of them did tremendously well with that. So I'm just going to show you a couple of videos here. Can you start? So this is Jessica. Now, I saw Jessica 4 years ago. She came in on a wheelchair. She could not move, 5 years. Nobody diagnosed her, ignored conversion disorder. And then finally somebody said, you may have CRPS after 5 years. Stop, please. And Jessica, we did ketamine for her. We did 10 days. She could not move. She could not stand. She can barely move her arms and legs. We did 10 days for her, which is usual protocol. Her pain went down from 10 to 9, and she still could not move. I told her to go back to Buffalo, put a line in a port, and she came back. And I had to do about 8 weeks of ketamine for her with intense physical therapy, and intense muscle stimulation during the infusions. And this is how you were seeing her getting out of the car, and she was walking with the walker. Now, the sad part is, yeah, thank you, that Jessica is in Buffalo and she could not come in. She could not come in as often and could not get treatment. I gave her a few boosters. She did great for a couple of years. And then because of family issues over there, she could not come. And Jessica passed away last week after she was able to walk with a walker after she was 5 years on a wheelchair. My main point with this is early treatments and don't give up after 10 days of regular infusions. That many patients may really benefit from longer than that. This is Paul, and Paul had inclusion body myositis. Could not move, was told this is a terminal condition, nothing else could be done. And he wanted to attend his son's wedding, and he's playing and having fun right now. Can we move next one? Okay, this is Bella and Lizzie, and this is part of maybe what Dr. Young was talking about, genetic. They're two sisters, 13 and 9, and they were basically almost wheelchair bound, from CRPS, and they have been now almost 2 years in remission. And we were very aggressive with them, had to do more than 2 weeks, I believe, with Lizzie. Bella responded very good, and they're perfectly fine playing ballet and swimming and having a normal life. We'll go to the second one. Yeah, she was on a wheelchair, and now she's just enjoying life. Now, this is Tommy. Tommy was a very interesting case. Tommy had CRPS. He could not move too much. He had severe excruciating pain that will make him scream, even in the ride of the car from any little bumps. After 2 weeks, we could not help him. He came from California. We extended the duration another 2 weeks. One day before he leaves, at 2 a.m., woke up in the morning and told his mom, my pain is gone. Tommy now graduated from his school, and he is doing much better. His pain is doing significantly well. And again, this is another proof of just not giving up and saying it did not help. We did a lot of physical therapy with Tommy. We included also blocks during the infusions. We did whatever we could just so he can help. And this is Arlene, also very sad case. She was suicidal, severe pain, could not move too much, and did tremendously well with the ketamine infusion. Yeah, this is when she was getting the dystonia and severe spasms. Now again, she's functional and doing tremendously well. So again, my main point is incorporating muscle stimulations together with early aggressive treatment with the ketamine, higher doses with the ketamine. A lot of the patients we get already had ketamine, but the doctors could not go to any higher doses. So those who failed lower doses and who failed short duration, there is still hope. They can benefit from higher doses, longer duration, and administration of muscle stimulations and physical therapy. We also combine a lot of other medications with the ketamine. We don't use ketamine only. So any questions?
Regarding RSD, for those patients who had it for quite some time, 10 or longer years, is a ketamine infusions going to be helpful, or the brain neurons already made its mind up where it's not going to be helpful for changing the pain receptors?
No, we had many patients who have been over 10 years diagnosed, and we got good benefit. I'm not saying it's a miracle cure, but it has definitely helped a lot of patients. And yes, it did work, and we tried it for them.
What benefits have you seen for fibromyalgia?
Actually, I had a patient with fibromyalgia. She was the CEO of a Fortune 500 company, and I told her about ketamine, and we did it, and she has been 2 years pain-free. And I had other patients who get fibromyalgia, get much longer response. I get usually 3 to 6 months duration of relief. So I get much better response than CRPS. Again, fibromyalgia now is a small fiber neuropathy. Again, it is a central sensitization syndrome. It is kind of like the little sister of CRPS.
What are the insurance protocols for ketamine therapy? Are they covering it yet? Or?
Well, it's a struggle with the insurance. We bill insurance. We do take insurance. We try to help all patients as much as we can. We understand, ketamine itself is cheap, but it's administration and the nursing and the supervision and place and all of that. And we understand, there's a lot of, expenses with it, and a lot of doctors charge higher amount of money. But we do take insurance. Insurance, they pay for it. Some they do, some they don't. So we try our best, and it's a hit or miss. Most of insurance pays actually, unfortunately, below our cost, but at least they pay something, and we're happy with it.
There are several studies in the literature that say that ketamine in HIV/AIDS is actually an immunosuppressant. So you talked about immunomodulatory. It seems to me that your ketamine may be acting in the way something mild like Cytoxan works, but clearly these patients are so inflamed from their autoimmunity, it makes sense what you're doing. I also want to ask a question about the patients with fibromyalgia. Did they have skin biopsies for small fiber?
I didn't do the skin, but I actually got the kit. It was like, her date of expiration was done. So I didn't do skin biopsy for her, but she had excellent response. And my next, research was to try to incorporate skin biopsy for that. And definitely ketamine is a neuromodulator, that's for sure. And we find a lot of benefit with autoimmune disease, as I saw it with, like Lyme disease, chronic Lyme, which is probably autoimmune, with lupus, rheumatoid arthritis, all of those diseases. We had, great response, from it. It's excellent for neuroinflammatory disease, and I believe I did it for a patient with Parkinson, got a tremendous response. Basically patients, in the office was moving like this. I gave her a little shot of ketamine, and basically it stopped. Pardon me? Yeah, I believe it's the most potent neuroinflammatory, anti-neuroinflammatory agents, in the market. And I believe it can help Alzheimer, and that's my next case, patients to try on. But it's a great drug.